So I'll leave the floor to Professor Sharland now to start his presentation.
Thank you very much indeed. And if I can have the first slide, that will be very helpful. So thank you very much indeed, Jürgen, and thank you for the excellent videos, which I think laid out very well the challenges of antibiotic resistance, and the issues that we need to tackle today. Next slide, please. So there has been, since the Global Action Plan, now quite a lot of political advance in antimicrobial resistance in terms of setting up a global structure at the WHO, talking about now a global structure at the United Nations, and there's now an independent panel for evidence for action against antibiotic resistance, which is similar to the independent panel for global warming. What there hasn't been is any practical steps to improve anything on the ground. And that's a problem because at the moment, antibiotic resistance is already a major problem and unfortunately is only going to get worse. Next slide, please. One of the reasons for that is because there are very few antibiotics coming through, new antibiotics. There's only been about 10 new antibiotics licensed in the last 5 years, and they're pretty much the same as the ones we have already. If you look at phase 1, phase 2, and phase 3 clinical trials against the WHO priority pathogens, these are the antibiotics that are going to come through over the next 10 to 15 years. There's very little new in there either. Half of these are very well-established classes. Very few are oral, they're nearly all intravenous, and very few are focused on the SBLs, which are one of the most common resistance still seen across in many children's settings. Very few have any innovative mode of action against multi-resistant infections. And for carbapenem-resistant infections, for Asia, for example, and now large parts of Africa, there's a particular type of carbapenem resistance, metallo-beta-lactamase, which is the key problem. And there are very few drugs that are active against that. Unfortunately, most of the new antibiotics are targeted at the type of carbapenem resistance that are commonly seen in the USA. And unfortunately, there are very few that are targeted against those infections most commonly seen in the lower middle income setting. Also, the pathogens that are most important for children, in particular, Klebsiella, E. coli, and gram-negative, very few of the new drugs in the preclinical pipeline, these are the ones that are coming in the next 20 years, are actually targeted against those either. So it's really clear that not only the antibiotics that you're using now, cefotaxime, meropenem, piperacillin, tazobactam, are the antibiotics that you still will be using in 10 to 20 years' time. And so this is a serious and significant issue. Next slide, please. So what can we do? Well, we have to conserve what we have better, clearly, because it's going to have to last us for quite a while. And the WHO have now tried to produce simple classifications of antibiotic that Jürgen was talking about. These are just traffic lights: access antibiotics and narrow spectrum antibiotics, penicillin, amoxicillin, the drugs that we know well and that we've been using for decades. Watch group antibiotics are broad spectrum antibiotics, ceftriaxone, macrolides, azithromycin, and reserve are the last group antibiotics, colistin, and the types of antibiotics we have to use really at the very end for multi-drug resistance. And there is now also a new group on the WHO essential medicines list, which is not recommended. And this is a group that is often fixed dose inappropriate access. And so what we now have is the WHO have developed guidelines, targets that are suggesting that at a country level, at least 60% of prescribing should be access group antibiotics. And indeed, in the community setting, as we'll come on to, probably that should be even higher. Next slide, please. So Jürgen was talking about the sort of antibiotic and we were also discussing point prevalence survey data. So, and we can also look at total consumption data. This is data looking at overall use. And on the whole, for many countries, children do receive a lot of access antibiotics, a lot of amoxicillin. Equally, in other countries, both high income and lower middle income, a lot of oral antibiotics are actually a broad spectrum watch group antibiotics, far too much. And also in many lower middle income countries, there is data that children do receive a lot of antibiotics, 5 or more courses of antibiotics a year. In a recent large systematic review, it was shown that children were receiving in many lower middle income countries 25 to 30 courses of antibiotics in the first 5 years of their life, which of course has an impact on their own microbiome as well. Next slide, please. So one can use simple tools, and we haven't got time today to talk about them, but simple point prevalence surveys, not only to look and see what is happening overall in your hospital, but to try and to look and see whether particular conditions, and this is pneumonia, for example, are people using broad spectrum antibiotics inappropriately, or are narrow spectrum antibiotics being used? So this type of simple tools, just ratios of green and yellow antibiotics, can be helpful and very easy to take forward at a sort of facility level or on an outpatient level. Next slide, please. We know there are a lot of antibiotics used for children. We have can identify that there are probably many billions of antibiotics. I mean, it's hard to calculate exactly, but around 4 to 5 billion courses of antibiotics given to children globally. So it's a huge, and it's by far and away the most common medicines that children receive. Next slide, please. The most common antibiotics we've seen are amoxicillin, clavulanate, cotrimoxazole, cephalosporin, but also quite a lot of other broad antibiotics as well. And one of the problems, and this slide shows it, is that actually there's still a large amount of syrup being used internationally, and quite a lot of inappropriate formulations, and still quite a lot of inappropriate broad spectrum antibiotics being used, particularly in the primary healthcare setting. And that often can be, of course, we know, through drugstores and through other informal providers as well. Next slide, please. So as Jürgen was discussing, these WHO essential medicines list have not only done what you should have on the list, which is traditionally what the list has been doing, but how to use that. And so later on this year, there'll be a new antibiotic handbook. This is 36 different infections, nearly all the common infections that children get and adults. It has strong focus on primary care, but also includes facility hospital setting, pneumonia, meningitis, common in abdominal infections, and it's really focused on empiric antibiotic treatment where there is no laboratory diagnostic. So what is the commonest empiric? And it talks about how to make the diagnosis, the decision of antibiotic needed, the drug dose and duration. In particular, it does give simple guidance on when the child or the adult doesn't probably need antibiotics, and it's perfectly okay to take a watchful and waiting approach. And the target audience is all health professionals giving antibiotics. Next slide, please. And you can see that this is for common primary care infections, pharyngeal ear infections, throat infections, mild chest infections, urine infections, dental infections. Access antibiotics, predominantly amoxicillin, will be the most likely recommended antibiotic. And there's really very few cases in the community setting where you do need to use a watch group antibiotics, bloody diarrhea, dysentery, clearly, but all the rest of them most commonly. So in fact, really around 90% of antibiotic prescribing in primary care can be access antibiotics. And this allows organizations to consider their own guidelines and consider trying to monitor those outcomes, and to also extend their education out to other linked groups, particularly local providers, and expand out into the community setting. And I think we also need to think about trying to identify how children, and in the hospital facility, also whether they should be receiving a watch group or access antibiotics. And then that many of the guidelines will be developed in this way. Next slide, please. So just trying to keep to time, I think it's fairly clear that actually for the great majority of bacterial infections in primary care, they can be treated effectively and safely with our current narrow spectrum access antibiotics. Interestingly, for around about 90% of global antibiotic prescribing, there is no problem with antibiotic resistance. Actually, the problem is antibiotic use. Around half the children in the world receive watch antibiotics, and many, many children receive inappropriate multiple courses of broad spectrum antibiotics, which all they're doing is adding cost to families and providing more side effects. Unfortunately, the novel and the new antibiotic pipeline coming through in the next 10 to 20 years are going to have very few new antibiotics. The Global Antibiotic R&D Partnership that I work with is basically similar to DNDi, an offshoot of DNDi, and are trying to develop and consider antibiotics that are new antibiotics and novel old off-patent antibiotics that could be taken forward into future WHO guidelines. And we hope to be starting a whole series of trials optimizing neonatal sepsis treatment, which I can talk about later. As was discussed very clearly, nosocomial infection, MDR infection in facilities is a real problem. Children in African hospitals acquire ESBL, multi-drug resistant infections, at 10 to 20% a day. And so we really have to focus, does that child need to be in hospital? Really, we have to think differently about the way in which we provide hospital care in the future. Question every day whether it's appropriate the child should be in hospital, because hospital acquisition of infection now is so important, is so high. And we also need to really, at a policy level, we need to think about detailed goals and detailed targets for stewardship for children and adults that will actually tackle this very serious AMR problem. Thank you very much indeed for your attention. Thank you.
Okay, thank you very much, Mike, for the nice presentation and the overview. I think you have highlighted some very important aspects, like also the focus on outpatient care. So it's not just about hospitals, but I think also what is happening in outpatients and even community settings. I think it's worth mentioning also the fact of the problem of ABUs more than antibiotic resistance in some contexts, the importance of the nosocomial infections. And I think also the need to have clear targets, because this is also something that is quite challenging. I think also in MSF, like how do we define our targets? What do you want to reach in terms of antibiotic use, antibiotic resistance, etc.? So thanks for this presentation. Maybe just a question for clarification. You mentioned briefly the work of GARDP. Can you elaborate a bit more on where they are currently?
Yes, so GARDP is a collaboration that was from the WHO and Drugs for Neglected Disease Initiative, DNDi, and is very aware of the issues for neonatal sepsis or pediatric sepsis and the difficulty with the current WHO conditions. So GARDP have developed a program of work looking at combinations of old off-patent antibiotics, cheaper, generic antibiotics, where they haven't been used for decades, and so there's lower levels of resistance, and also are collaborating with a number of companies now, pharma companies, for new antibiotics, and then thinking through the finance models similar to the DNDi approach. So we aim to be starting a global trial, hopefully getting going actually quite soon, the next month or so, looking at combinations initially of old off-patent antibiotics, having just completed a large global neonatal observational study, and then thinking about introducing into that trial using novel clinical trials designs of new antibiotics coming through with appropriate models associated to make sure those drugs in the future will be registered and then eventually licensed and available in the countries similar to other global initiatives such as HIV and TB, etc. Yeah, thanks, Jürgen.